Thank you. I'm glad to be here with you and share with you the European experience, let's put it this way. So my talk, I will give 50% of the talk. I will share with you the recent, not as recent as the US, but European guidelines for parental nutrition. And the second part of my talk, I will share with you some of our research data and enthusiasms we have concerning lipid emulsion. Well, we always refer to the lipids, and we always know about the triglycerides, and we identify a lipid emulsion by the triglyceride component of it. But the situation is sometimes more complex as we have different ingredients. And this is an old slide on mine made in 1984, where actually, with a Macintosh, where actually you see that lipid emulsion contain glycerol, phospholipids, and you have ethanolamine, choline, you have triglycerides from vegetable source and from fish or natural sources. You have different cholesterol, esterified cholesterol, progesterol, vitamin, and so forth. So the situation is really a bit often more complex than what we normally depicted. So you need good trials, and especially because the matter of fact, this lipid emulsion were designed for adults with the purpose of oxidation and energy. An adult don't need to grow, need energy and a good oxidation. So little attention, well, some attention has been given to the impact on immune function, but we have far fewer studies for that. And even less attention is being given to providing the building blocks for the brain in a rapidly growing infant. So I think sometimes when we look at the lipid emulsion, we have really to see how much evidence we have in these different domains also. So we were used to have guidelines in 2005. They were very old. So in 2016, we decided that we would develop or we would update these guidelines. And they came out in 2018. We have ASPEN, European Society for Pediatric Research, the Chinese Parental Nutrition, in a joint effort. This is the group of the people, and we have 46 people that participate to this initiative. And we had the publication in late 2018. Well, I would, in the next 10 minutes or so, I would like to summarize what was decided or what we came up with. And for the sake of comparison, on the left, you have the 2005 recommendation, and on the right, you have the 2018. And perhaps we can comment what changed over these two decades. Well, they are integral part of parental nutrition, and they should protect it by light. This is unchanged. Well, what changed over the time is in 2005, the recommendation was to start lipids not later than on the third day of life. And more recently, it says not later than day 2 of life. And actually is recommend to start lipid as soon as we start parental nutrition. On a personal basis, I can tell that parental nutrition in my unit is started at 75 minutes of life. And we start, of course, in a single component lipids, carbohydrate, everything within 1 hour, 1.5 hours after birth, as soon as the patient has a venous access and stabilization. That is common practice in Europe, let's say, this way. So, essential fatty acid. We give lipid for energy and essential fatty acid. It was felt in 2005 that 1/4 of a gram linoleic acid, 250 milligrams, is sufficient for preterm baby, and 1/10 of a gram, 100 milligrams, is sufficient for term babies. And this recommendation is unchanged. Well, how much lipids? 3 to 4 grams in 2005, up to 4 grams in not exceeding 4 grams in 2018. But I shall come back to that because it seems quite a high value, but it's associated with some kind of monitoring. Lipid should infuse over 24 hours and should infuse with other lipid component in case of cyclic PN, but that's not very often prescribed, cycling PN. Well, what is different here is that in preterm infant, it's speculated or is suggested that pure soybean oil may provide a less balanced nutrition than composite lipid emulsion, basically intended to mimic human milk or to provide a better balanced fatty acid. And for parental nutrition lasting longer than a few hours, pure soy ILE should be no longer used, and composite lipid emulsion with and without fish oil should be the first choice of treatment. That's what most of the people felt like this way. So, heparin, no change. Heparin should not be associated with any lipid. You know, it's causing big disaster, so it happens sometimes. So we felt re-emphasizing the heparin should not be given with lipid infusion if necessary. Well, what is somewhat different is that in Europe, many of us do measure routinely triglycerides concentration on a regular basis. So the recommendation is to do so, and there's a strong consensus and strong recommendation, and the reduction of the dosing on its when the triglyceride level are above 260 milligram per deciliter, which is 3 millimole for small infants, preterm infants, and for older infants is 400 milligram per deciliter. This is somewhat different. Well, in critically ill infants, again, composite lipid emulsion, with or without fish oil, should be the first choice of treatment. And in patients with sepsis, more frequent monitoring of plasma triglyceride concentration is recommended. In case of thrombocytopenia, the platelet function is impaired by high triglycerides. There are plenty of studies on that, so we came up with a recommendation that triglyceride concentration should be within with normal limit in thrombocytopenic patients with low platelets count. Well, we felt not adding additional recommendation on essential fatty acids, as you know, this 1/4 of a gram, 1/10 of a gram still hold true. Benefit of lipid emulsion that were stated in 2005 are there, and there's no need to re-emphasize that. And no recommendation concerning bilirubin and jaundice, because I think it's kind of accepted that if you keep your bilirubin under control, the lipid infusion is not really worsening the risk of kernicterus and so on. So not even mentioning, is not even incorporate this consideration. In case of EFLDs, discontinuation or reducing the dose should be considered, but we didn't feel taking any position of that. And pure fish oil is not recommended, was not recommended by the group, only for short-term rescue treatment for a very limited period of time. There's also relatively, I wouldn't say lack of data, but limited data on that. Carnitine, the recommendation persisted unchanged 20 years later, can be used after 4 weeks of exclusive parenteral nutrition when enteral intake is minimum, insufficient to provide oral carnitine, which is abundant in infant milk formula and so forth. So I'm sure this will open some question, and you can discuss on the differences across the ocean. Well, the second part of my talk, I would like to tell you briefly what we have done with the study we performed, well, over the last 10 years to learn more about lipid emulsion. Of course, the starting point is that all lipid emulsion are very different from human milk. And of course, human milk is the best lipid source. Human milk lipids are the best source. And of course, we would like to mimic that as much as possible. So we studied basically 5 lipid emulsion as they are commercially available in Europe: soybean and MCT 50-50, soybean MCT at 10% fish, soy MCT, fish and olive and soybean. We have 100% soy, which you're familiar with, I'm sure, and soybean oil 20 and olive oil 80. And those are the different options in different situations. And the focus, of course, was brain development. So in the first study we performed about 10 years ago, we obtained some preliminary information that we were somewhat not happy to find in a way. Of course, we compare here fish with MCT and soy versus MCT and soy, simply because this study, this MCT was the best comparator. If you want to see what the effect of fish oil, you compare with something that is very similar, but the fish oil, right? So we performed this study, and indeed we found the fatty acid composition, apart from long-chain lipids, was rather similar, I would say. But please note that arachidonic acid was twice as high with fish. Let's not forget there is significant amount of arachidonic acid in fish oil. So you gave some arachidonic acid, and it's twice as much as in the conventional formula. EPA is very high, and DHA was also much higher in this formula that had only 10% fish. Please, I'll remind you, there are other formulations with 15% fish. So the small group of babies, similar fat intake throughout, the postnatal age. These are the intakes. Arachidonic acid with the fish was twice as high as in control, DHA way, way higher, and EPA extremely high intakes. Well, the first things we found with the fish oil, 10% fish oil, plasma phospholipid were lower. Triglyceride tended to be lower. Free cholesterol was significantly lower. Cholesterol ester were markedly lower. So that 10% was associated with lower plasma lipids. And next to it, of course, we found that arachidonic acid in plasma phospholipid, in spite twice the dosing, was significantly lower. Higher EPA and higher DHA, but that was expected because of the composition. And that things persisted up to day 14. These are the same data in graphical format. You see DHA being lower than in cord blood, but much higher with the fish. You see EPA being 10 times, I guess, wait a second, nearly 10 times the controls. And arachidonic acid, that in spite twice the intake, double the intake, was significantly lower. So we start not being completely happy with this scenario, let's say. And well, we could conclude that by giving only 10% fish oil with a good comparator, lower free cholesterol, lower cholesterol ester, lower phospholipid, and we didn't know how to interpret that. Higher DHA, higher EPA you would expect, but the lower arachidonic was a little bit and something we did not, well, you could expect that, but we didn't expect such a magnitude for that change. So we look at what happened with 15% fish. That was 10% fish. So with 50% fish, we did a study where we changed the dose and we changed the emulsion, and we compare with 100% soy. To keep a long story short, this is a study design, and what it was very clear, the plasma lipid were much, much higher with the 3.5 gram per kilo per day as compared to the 4 gram, and the same effect of the fish oil, lipid lowering effect of fish oil was there. Of interest, late onset sepsis in this study was significantly higher in the baby that got 3.5 gram per kilo per day in both groups. This is ANOVA, you cannot really tell, but altogether they had higher sepsis. Well, this was really bothering us. Why? If you're an adult, you lower triglyceride, you're happy, right? If you're a small baby, you lower your plasma lipid. Is that as good as in adult? So we try to tackle this problem, and the way we measure lipogenesis. Lipogenesis is the process where you biosynthesize endogenous lipids, which is essential for myelin formation in the brain, is essential for surfactant synthesis, is essential for several physiological processes. So we dose the baby with deuterated water, which is stable, non-radioactive. We measure the incorporation of water into polymers, lipid, biosynthesized lipids. And what was striking, or what we could demonstrate, this is still, I think, an interesting piece of data, that palmitic acid, oleic acid, the stearic acid, were all, their synthesis was significantly depressed by fish oil. So fish oil has a strong effect on the biosynthesis of lipids. So at that time, was 2016, we concluded that although we measure lipogenesis in the general circulation in the liver, and we could not speculate what would happen in the lungs, we have data in the lungs and in the brain, we still have no data in the brain, still this information, this data were of concern. Therefore, we concluded we recommend the medium long-term neurodevelopment respiratory follow-up studies should be performed before the widespread use of fish oil lipid emulsion in the vulnerable growing preterm infant. That was our conclusion in 2016. Well, what we could do quickly is say, does this fish oil affect the growth of babies? Well, keep a long story short, no. The fish oil baby actually grew slightly better, 16 grams per kilo per day versus 15. So that you don't see it in, impairing growth, by measuring daily weight or growth velocity. And these are the similar data. I apologize, this is a bit of repetition. So at least we were reassured that the fish oil did not have a negative effect on growth. But another paper came in New England that was really disturbing to us. The Australian, they do these fantastic randomized studies. They gave large doses of oral fish oil to babies as soon as they could tolerate enteral feeding, up to 36 weeks of age. And their purpose was reducing bronchopulmonary dysplasia under the hypothesis this is inflammatory process. 631 babies got the fish oil oral, 642 were controlled. Contrary to their hypothesis, not only they reduced BPD, but they increased BPD. BPD was significantly higher in the group of babies that received the fish oil. And that was quite, to us, quite a disturbing signal, let's say. So we immediately, that was 2020, look what happened to the lung function of our babies that received the fish oil containing intravenous lipid emulsion. And the way we assess lung function, let's say, or that, was by measuring the saturation over FiO2 ratio. So this is the ratio between oxygen saturation in the blood and the FiO2 needed to obtain that saturation. And wow, what we found, the baby got the fish oil, had a worse SFR, saturation over FiO2 ratio, indicating somewhat lower lung development. We developed further this technique. Now we have a much more sophisticated technique. We use force pulse oximeter attached to the forelimbs, and we measure FiO2 in a very precise way. And it's a computer system that removes artifact, motion, artifact. We get a very high precision and reproducible measurements. And indeed, this SFR was significantly worse, lower, in the baby that got fish oil as a component of a lipid emulsion. So this is something that is of concern to us. The matter of fact, we limit the use now these days. And we, however, concluded in this paper that in a very cautious way, the use of fish oil lipid emulsion for routine PN for the preterm infant did not improve lung growth, as somebody hypothesized, compared to infant. Actually, it makes the SFR worse. So, is there any advantage in neurodevelopment, which is probably the major objective why we all were enthusiastic 10 or 15 years ago, to jump to the composite lipid emulsion with fish oil. So we look at our cohort. In our cohort, we have 477 babies between 400 and 1,240 grams. And we have complete follow-up data of 167 in the fish oil group and 177 in controls, which means conventional lipid emulsion. And the cognitive score at the Bailey was 92 and 93, not significant, 1 point less. The motor was 9800, and there is a trend to significant, 0.05, being lower with fish, and language is also 1 point lower, not significant. So, yeah, that came to a big disappointment to us. And we had to conclude that, contrary to our hypothesis, the use of fish oil-containing lipid emulsion did not result in a better neurodevelopment at 2 years. So we are a bit stuck now with this study. We continue our study. Now we do better randomization. We start all kind of randomized studies, but they are not to be presented yet, or they are ongoing, let's say like that. I think I stop at this point. I think I showed you what we have been looking for, some of our research, some of our ideas, at the same time what is felt to be important in Europe. The questions are very welcome at the end.